So thank you very much for that introduction, Steve, and hello everyone. This is Sarah Charters, and I'm giving you my presentation from Southampton. First slide, please. So NHS Improvement put forward national priorities for acute hospitals in their document Good Practice Guide, focusing on improving patient flow. And a key point that they put forward is that the ED should prioritise the assessment and treatment of the sickest patients, including those presenting with time-critical and potentially life-threatening conditions, frail older people at risk of admission, and vulnerable patients, including children, people with learning disabilities, and those at risk of self-harm. Now, in Southampton, we look quite broadly at the issue of time-critical and potentially life-threatening conditions to include a whole range of psychosocial problems with patients who often come in slightly chaotic and sometimes not wanting to stay in the emergency department for too long. And we've introduced an innovative way of meeting the needs of that patient group. Next slide, please. So just to give you a bit of background, I've been an emergency nurse since 1990, and I'm also an RAF reservist, again, since 1990. Throughout my career, I've been absolutely passionate about supporting vulnerable and disadvantaged patients. I was really fortunate in the early 2000s to undertake a consultant nurse training programme, in fact, the first of its kind in the country. And within that, I undertook an entrepreneurial module. And I was really lucky because that actually taught me what I wanted to do with my future career. I'd entered the programme, wanted to be a majors nurse practitioner. And the entrepreneurial module talked a lot about setting up your own business, which I didn't want to do, but it made me realise I could set up my own job. And I put together a business case for a consultant nurse post, leading on the care of people with adult vulnerabilities or mental health needs, and was fortunate enough to get that post once we advertised. My whole role is relating to managing psychosocial issues, those which underlie the healthcare needs of patients presenting for emergency care, and that's those who present for both physical and mental health care. And I spent the first couple of years of my role focusing on policy and procedure and putting together lots of education programs for our staff. And you'll see there a lady in a picture with me, the middle picture, who was a project worker who assisted me one day a week. And we felt like we were trying to change the world, which was quite a difficult thing to do in a busy emergency department. Next slide, please. So the challenges we faced were the emergency department team would have patients who they could see were distressed or in need, but they were competing with time pressures, other priorities. Many of our nurses have 6 to 8 patients to look after all in one go, and so taking time out to spend with one person could be really difficult. Time for education has reduced as clinical pressures have gone up, and so being able to maintain the knowledge base of our staff in the care of these vulnerabilities was quite difficult when you add it to all the things they need to know about delivering physical health care. And each individual staff member had quite an infrequency of exposure to some of the vulnerabilities that we manage, such as domestic abuse and homelessness and substance use. And as a consequence, they'd often have skill fade. I could give them a jolly good teaching session about how to manage a disclosure of domestic abuse. And then if they didn't come across someone who was experiencing domestic abuse within the first 3 to 6 months, they would lose some of that knowledge and some of the skill that I'd given them. In the emergency department, as well as many other healthcare settings, we have quite a transient workforce, and many of our doctors are only with us for 4 months, and we have quite a young nursing workforce, and many of them see ED as a sort of stepping point for their career. And added to that, there's such a wealth of community support out there in our local area, and trying to keep all of our staff knowledgeable about all the different places they could refer people to in an ever-changing environment was tricky. And then, as many of those of you who work in cities will know, we have services which were relevant to Southampton residents, which were different to those relevant for Hampshire patients. So quite a complexity of issues that made giving really good interventions quite a challenge for our team. Next slide, please. So the solution that I came up with was to introduce a vulnerable adult support team, and I was really fortunate to be successful in gaining an initial funding from an innovation fund which our local council and CCG put up, and I was able to get funding for 12 months to trial the concept of having the vulnerable adult support team, or as we call it, VAST. And so just so that people had job security, I set the posts up initially as secondment posts, and we had AFC Band 3 staff initially who came from the HCA team, and they worked from 2 till 10, 7 days a week, using national and international risk tools which were recognised and gave us a common language across agencies. And we work really closely in liaison with specialist teams within the hospital, including the alcohol care team, the dementia care team, our liaison psychiatry team, and then a whole wealth of community services. And the way I set up the induction for my team members was to give them 8 days induction, and much of that time we spent visiting all the different agencies that we refer our patients into, so the staff could see the service in situ, meet the staff who are running the service, so they had face-to-face contact, and then hear about the service from the people delivering it. Our ethos is around making every contact count, and the idea is that anyone who comes into ED with some form of psychosocial problem should have a really relevant and person-centred intervention from our team, and we deliver our service within the realms of motivational interviewing, whereby we come alongside the patient and try and understand the problem from their perspective, what blocks they've found when interacting with community services or hospital services, and how they would like us to support them to address the issues they're facing. So we deliver a brief intervention where we screen and identify the different issues that they're experiencing. And a key thing that we've found is that someone who comes in with issues around domestic abuse may also be experiencing problems with potential homelessness if they're planning to leave the relationship. They may be using substances to cope with the abuse. And so we frequently find that people don't present with one psychosocial problem, but they present with 2 or more. And so with the team I set up, we can actually address all of those issues with one practitioner, rather than them seeing the alcohol nurse and then the domestic abuse outreach worker and then perhaps the homeless support person. The team can provide that initial intervention for all of the problems. So, as I've said, we use nationally and internationally risk assessment tools, and then we offer to reflect back to the patient the level of risk that we think they're at, and then provide them with information about the issue, help to normalise it, because we know so many people are facing these psychosocial problems, and then we offer signposting and referral to community services. And we also safeguard our patients either through adult or child safeguarding procedures, because we know that a certain cohort of our patients are unable to fully protect themselves because they're an adult at risk, and we know that children are frequently exposed to choices, behaviours, issues for their parents, which have a massive impact on them. And we also safeguard through the high-risk domestic abuse processes for people who we think are at high risk of being murdered. Next slide, please. So I wanted to start the presentation almost backwards by telling you about some of the outcomes that we've had from introducing our service. And to do this, I was going to tell you about two patients that we've recently managed. So the first was a chap who was, he'd come across to the UK from Eastern Europe. He was quite a successful businessman, and then he started drinking, and his life steadily fell apart. And he lost his relationship, had to move into rented accommodation, and then had a dodgy landlord who'd actually stolen belongings from him, moved on to another landlord, and found himself with no finance and was being evicted, and so had the prospect of street homelessness. He didn't have all his benefits in place, and so he had issues around finance and alcohol and homelessness. And my team member, as I said before, we try and come alongside the patient to understand what they want. And we started thinking that we would provide him with referrals into the homeless and alcohol services. But in fact, what he wanted was to go back home to his family. And so my team member worked with his embassy and with a church group in the UK from his country, and through those two agencies managed to facilitate a train pass to London, a flight to back to the country that he came from, and he was back into the care of his family. So that was one episode where we had a really good person-centred approach. And the other was a lady who during COVID-19 has been living in a tent in Southampton with a domestic abuser who had mental health problems. And we saw her on a number of occasions, and each time she came in, her injuries were worse. We referred her to the police from a murder prevention perspective on a couple of occasions, and the police came in and interviewed her, but she always had the partner waiting outside and was always desperate to get back out the door again, because she knew that she would potentially be more at risk from him if she spent too long with us. So we were the one constant team that she would engage with, and because all the other agencies were working by telephone and she didn't have the privacy in a tent to be able to speak with an advocate, we were the only source of help to her. And in the end, she came in again, we would say, have been at severe risk of being killed by her partner. And although she wouldn't give a statement to the police, she allowed us to give a statement on her behalf, knowing that the partner would be arrested. And then she was able to access services and the support of her family and move out of that life-threatening situation. So that's the type of work that we do, and my team are working with very vulnerable people on a daily basis, providing that really person-centred care. And just to move on, next slide, please. The other great benefit from our team is that we release time to care back to our ED clinicians, because we have the expertise within our team to deal with all of these issues. So all the clinicians have to do is tannoy or give us a phone call or pop round to the office and refer their patient to us, and then they can carry on and concentrate on the physical health, or for the liaison psychiatry service, the mental health care, and we deal with the psychosocial problems. So by introducing this work, we have improved substantially the patient flow through our service, because our clinicians used to spend quite some time trying to work out the best way to address the problem without the expertise that my team have. Next slide, please. And another outcome for our service is that we've created superb links with a whole range of community services and hospital-based services. And as the manager of our local IDVAS said, since our inception, the VAST service has been proactive in making the links, networks and developing pathways outside of the hospital community. And we've had several agencies remark on how we are able to engage very difficult to reach patients who hadn't previously come to their attention, but because they've come to the ED in crisis and they've been at a point where they feel ready to make change, we've been able to help them at that point. Next slide, please. And I'm really pleased that we have also been identified in 2 consecutive CQC inspections as an area of outstanding practice within our hospital. And I'm sure you can read as well, but I'll read with you. The arrangements for supporting vulnerable patients and other service users was exceptional. The knowledge and resources within the vulnerable adult support team ensured patients were supported in line with national best practice standards. We observed episodes of care during which patients were truly respected and valued as individuals. Patients were empowered as partners in their care, both practically and emotionally. This was especially the case for those patients who presented with mental health problems or those who were recognised as vulnerable. And we have also received really positive feedback through 2 more CQC inspections, one relating to mental health care and one related to safeguarding children who live within families where domestic abuse occurs. Next slide, please. So this is obviously a conference about patient flow. And so I'm using the work from the NHS Improvement just to talk further about the team using their good practice guides around flow. So the first thing is flow is a team sport. And they advocate that all organisations, departments and staff groups in and outside of hospital need to collaborate and act together, for example, through shared assessments and interventions to deliver effective and responsive patient care. And what we've found with VAST is that we provide a really incredible bridge between the acute setting and community services. And we also help earlier interventions within hospital by referring admitted patients to specialist teams from the point of access through the ED. Next slide, please. And here's just a small selection of some of the agencies that we liaise with on a almost daily basis, some of the agencies you see here. And so it just demonstrates that we're delivering our service within part of a much wider team. Next slide, please. A really key thing is that to maintain patient flow and good care, we need focus from the top. And well, it sounds a bit big-headed to say that I'm at the top. I'm certainly at the top within my team, and then I have really good support from the managers who I work alongside within the division and at executive level. And the thing here is that the patients that we see are highly complex, and their care often needs significant unravelling to work out how we can best meet them, and as I meet their needs. And as I said earlier, often patients come in with multiple problems, and so throughout the lifespan of VAST, which has now been 8 years, I've been a very hands-on manager. And we have regular one-to-one meetings every month and education days. And also I have now my 2 senior team members are band 4s within the team, and they do a lot of internal assurance, reviewing case notes from the more junior practitioners, and the 3 of us are on call to the team pretty much whenever they need our help. If they need to review or discuss any complex cases. Next slide, please. And yeah, so as I said, we have really robust internal assurance processes, and each team member also has a special area of responsibility where they audit their own and their colleagues' work to make sure that all the right interventions are being taken for each individual patient. Next slide, please. So, as you know, the management of flow is really important 7 days a week, and that's a key thing for our team. When I set us up, it was to work both in and out of hours, and we started working from 2 till 10, 7 days a week, and now we have expanded and we have 2 practitioners on from 8 till 4 and then 1 practitioner on from 2 till 10. And then for overnight referrals, we have a referral form which we pick up in the morning. If people are particularly vulnerable, they stay on our clinical decision unit overnight, but most people can go home and we follow them up by telephone the next day. Thank you. Next slide. So flow is about case mix, and the NHS improvement document recommends that we analyse our case mix and make sure that our service meets the demand. Next slide, please. And interestingly, I thought that the bulk of our demand would be on the late shift because I had my visions of the nighttime economy and all of the issues that arise from that. But in fact, our busiest shift is in the morning. In part, that's because of people who've stayed overnight, perhaps because they've been intoxicated or too vulnerable to go home, or waiting for specific care delivery. And so we have focused more resources, as I said before, in the morning, and we actually provide a service through to the acute medical unit as well, because a lot of our patients follow through to their care. And the other thing that we as I'm sure all EDs have noticed, is that we have a huge number of patients who attend frequently, and we have quite a robust high intensity service user programme now. One of my senior team members works 4 days a week on that programme as a coordinator, alongside one of our consultants who we have funding for 2 days a week, and a mental health high intensity coordinator who works 3 days a week, and a persistent physical symptoms psychologist who works again 2 days a week. And that team, with my support, work together to try and provide better care for those patients who are presenting to us frequently, helping them to access sometimes more appropriate services than coming to ED. Next slide, please. Flow needs patient input, and it's really important for us in everything we do to make sure that our care is person-centred. We see ourselves as dancing with our patients rather than wrestling with them, because we want to ensure that any support we give them is actually what they want, because otherwise they will probably agree with us to be polite while they're in the hospital and then go home and not engage with any of the services that we've informed them about, or engage with any of the referrals. And so everything we do is person-centred. We ask for feedback from the patients as well, if they've got any issues accessing services, or any reasons why they are attending ED rather than other agencies, so that we can feed back and support change in our partner agencies. Next slide, please. And flow clearly needs to be maintained at times of pressure. And one of the things that I think has been hugely beneficial with VAST is that we have run a full patient-facing service all the way through the first phase of the COVID-19 pandemic. And we know that lots of agencies have been delivering their care via telephone, and I think it's been quite reassuring for our patients to be able to come in and have a face-to-face intervention. The only thing that we've done is that we've moved from being in civvies into uniform, and my staff members find that tricky because they feel that uniform can put barriers up, and so we aspire to go back to civvies as soon as we feel that that's safe. But other than that, full service maintained all the way through, and I know that we will be exceptionally busy moving into this winter. Next slide, please. So I'm nearing the end of my presentation, and I just wanted to give you the words from a couple of my consultant colleagues. VAST perform an invaluable service meeting the complex needs of a group of patients so often failed by secondary care. And without a specific team of dedicated individuals who concentrate on this complex group of patients, their care can be patchy, haphazard and substandard. Next slide, please. So VAST is a service where, next slide, we save lives, and next slide, we change lives, and I feel really proud of that, and I'd be really delighted to share more information about our service with you if you'd like to hear more and would like to email me. Next slide, please. I'm really happy to answer any questions you may have, and if you want to learn a bit more about our service, you can find a very nifty little video that we've had made, which is available on YouTube. And thank you very much. That's the end of my presentation.